Okay, great. Welcome everybody to the Bay Area Breast Cancer Forum. Thanks so much for participating, and on behalf of myself and my colleagues, I'm excited to have you here. And we've had a little bit of a break with the summer and then some glitches with security systems at UCSF, which blocked our emails. So we're really excited now to be back on track and to have you all here. As you know, Melody Gaolu, who's there, and you can see her, is organizing the Breast Cancer Forum. And it's really, if you want to be on the mailing list, please send her a note and send everything to her. Somebody says there's a very significant echo. Are you hearing an echo too?
I'm not hearing an echo.
Okay, good. So hopefully you won't. Thanks for everybody. So for everybody who's on, and I'll introduce our panel in a second, but at the bottom of the screen, you can see Q&A. And if you want to put in questions there, it's really nice because we can respond to each individual question. Don't put questions into the chat. You could put a comment, like put me on the email list or something like that, but don't put questions into the chat, put it into Q&A because it allows us to answer them live or in person, and for the individual who knows the most about it to answer it. So it makes a big difference. We love to hear from you. So you can see the web page there. We want to have your emails so that we can, get you signed up to get our emails. And we love to hear about new topics and what you want to hear about. Any feedback that you have is always greatly appreciated. And I don't know what we're going to do about, going back to in person at some point. I think the Zoom works out really well to allow lots of people access, and people have the opportunity to ask questions too. So if people want to send notes back to the Bay Area Breast Cancer Forum email about your thoughts about any in-person meetings versus keeping them at Zoom, let me know. But we're excited that the Zoom has been able to work so well for everyone. This forum is focused on two different areas. So one is, we just had the European Society of Medical Oncology meeting, which was what's referred to as a hybrid meeting. Now things are hybrid. That meeting was held in Paris. Very unfortunate that that happened to be the meeting that I was invited to and we couldn't go. So you can see actually Melody just gave you the email to send to in the chat. So you can copy and paste that and save it. So the meeting was in Paris, but all of our participation was by Zoom. But what's really interesting is this year, and I think it started last year, ESMO has become a really major meeting for breast cancer updates. Now, this includes all different cancers. It's like our American Society of Clinical Oncology or ASCO meeting, but they had just huge practice-changing data at ESMO this year. It was extremely well done. And so we thought that we would add in an ESMO update to talk about some of these data and answer your questions. So in order to discuss ESMO, I have Melisko, I think somebody well known to everybody, my colleagues in the breast oncology program and practice. And then we have Laura Huppert, who's a senior breast oncology fellow, soon to be a breast oncologist in her own right. And she also will talk about some of the topics from ESMO this year. And then we're really pleased and grateful to have Shagun Arora here, who is one of our hematology oncology doctors at UCSF, and has really served as a point person for interpreting some of the COVID information we've had in terms of how COVID affects our cancer patients, what's going on with boosters, who you can be exposed to or not, et cetera. And so we'll hear from Shagun at the last half hour of our session tonight. So we're really pleased and thankful that she's been able to be here with us to talk to us. So without further ado, I think that we've had a few more people sign on. I'm Hope Rugo in the breast oncology practice. We have Melisko, Laura Huppert, and Shagun Arora. So Laura, I think you were going to start. And the topics that we have are three for ESMO. One is talking about immunotherapy and the really remarkable progress we've made in the last 3 months in immunotherapy for breast cancer. and the approvals and some of the data that led to that. And Laura will talk about that with the immunotherapy drug pembrolizumab, or Keytruda. And then Melisko will talk about an area incredibly important. We have about the majority, actually the highest percentage of breast cancers worldwide are hormone receptor positive. And we've made some big advances with cyclin-dependent kinase 4/6 inhibitors in both metastatic incurable disease and in early stage disease. And these data were presented at ESMO meetings in the last few weeks. One of them just presented last week in a freestanding session. So Michelle will talk about those data, I think, which are so important and also practice changing. And then there's been some really exciting advances in the treatment of HER2 positive disease. And hopefully we'll have time to just briefly talk about those as well, since I think people are overall more aware of that data, at least some people. So we really have covered, I think, triple negative disease, hormone receptor positive, and HER2 positive disease. So that's really helpful. So Laura.
Wonderful. Thank you so much, Dr. Rugo. Let me just share my slides. Great. Can you see my slides?
Yes, we can.
Perfect. So as Dr. Rugo mentioned, there's been tremendous updates in the triple negative space using immunotherapy, which is what I'm going to talk about today. And the first trial that I want to talk about is KEYNOTE-355, which looked at the addition of pembrolizumab to chemotherapy versus placebo to chemotherapy in the first line metastatic triple negative breast cancer setting. So before I dive into the data from that trial, I just want to remind everyone what immunotherapy is and how it works, which I've shown this animation in the past, but I think it's actually quite useful to remember why it works and how it works. So taking everyone back to high school biology, the dendritic cells are in the lymph nodes, and they prime the T cells. And T cells are one of the really important immune cells that then go on to fight cancer. And so once the T cells are primed, they go out into the peripheral tissues, they find the cancer cells, and they destroy tumor cells, which is what we would like them always to do. However, if T cells find normal tissue, like tissue in your colon or tissue in your skin, it can cause breakdown of these normal tissues and cause autoimmune side effects, which is one of the issues that we see sometimes with immunotherapy. So biology, basically, in addition to having these activating signals with the green bars, we need a way to turn off these T cells from being too active. And so those are what those red bars are. But in the context of cancer, we actually don't want the cancer cell to be able to turn off the T cells, right? Because if the cancer cell can turn off the T cells, then we don't have the ability to stop the cancer cells from proliferating. So what we have developed is these PD-1 inhibitors and PD-L1, CTLA-4, which are basically blocking the inhibitors. So it's double negative. So when before the tumor cell could turn off these T cells, we're basically blocking the ability of the tumor cells to turn off the T cells, so that now the T cells can continue to activate the death of these tumor cells, if that makes sense. So what we're going to talk about today is one of these inhibitors, a PD-1 inhibitor, which is called pembrolizumab. And so this study called KEYNOTE-355 basically enrolled patients that had triple negative breast cancer that were locally recurrent or metastatic. And they had to have adequate organ function, no systemic steroids, no active CNS metastases. And they randomized these patients to receive chemotherapy with the PD-1 inhibitor pembrolizumab versus chemotherapy and a placebo. So basically saying, like, does the addition of pembrolizumab help this work better? And then evaluated patients for progression of disease in the future. And so really exciting data was just released at the ESMO, as Dr. Rugo mentioned, which showed that progression-free survival was significantly improved with the addition of pembrolizumab. So in patients that had a CPS score greater than 10, which basically means they seem to have a molecule that indicates that immunotherapy would be especially active and work really well, there was an advantage of going from 5.6 months with placebo to 9.7 months with the addition of pembrolizumab, which is phenomenal. And then even in patients that had a relatively lower CPS score, there was still an advantage of 2 months difference. So collectively, this showed that the improved PFS was 4.1 months better with the addition of pembrolizumab in these CPS high patients and 2.0 months in patients with the CPS score that was greater than or equal to 1. And then the really exciting thing came out was the overall survival data. So in patients with triple negative, recurrent inoperable or metastatic triple negative breast cancer that had this high CPS score, the addition of pembrolizumab not only improved the progression-free survival or how quickly the cancer came back, but it also improved overall survival, meaning how much longer the patients lived, by a margin of 6.9 months, which is truly phenomenal. So really exciting data that adding pembrolizumab or this drug can improve patients' overall survival by almost 7 months. The downsides we always have to talk about, but what are the risks of these drugs? So like I was showing you in that immunotherapy graphic at the beginning, the risk of adding immunotherapy is that you can have immune-mediated side effects causing autoimmune side effects, basically. So with the addition of pembrolizumab in these turquoise bars, you had more thyroid side effects, you had an increased risk of inflammation of the lungs, colitis or diarrhea. So there was an increased risk of some of these autoimmune side effects with a 5.3% risk of serious grade 3 or to grade 5 immune side effects. But the good news is we're learning how to better recognize these autoimmune side effects and treat them early. So I think that there's more and more data about how to make these immunotherapies work as well as possible while reducing the risk of these autoimmune side effects and controlling them if they do happen. So the conclusions of this study is that by adding pembrolizumab to chemotherapy, it not only improved the progression-free survival or the time that it took the cancer to come back, but really excitingly, it also improved the overall survival of these patients by almost 7 months. And based on this data, the FDA announced in November of 2020 accelerated approval for the combination of pembrolizumab with chemotherapy for patients with triple negative breast cancer with a CPS score greater than or equal to 10. So really, really exciting data there. And the next study I want to talk about is along the same lines, but in early stage breast cancer. So this is the combination of pembrolizumab and chemotherapy versus placebo and chemotherapy for early stage triple negative breast cancer using the same drug pembrolizumab that I just described in the metastatic setting. So here, the eligibility criteria, patients with newly diagnosed triple negative breast cancer that had T1C or N1 to 2, so higher risk, basically early stage breast cancer, and then a good performance status. So they were randomized to receive chemotherapy and pembrolizumab versus chemotherapy and placebo, just like the last trial. And then they would get this neoadjuvantly, meaning before surgery. And then these patients would go to surgery. And then after surgery, if they were randomized to the pembrolizumab arm, they would continue on pembrolizumab to complete 27 more weeks versus continue on placebo in the adjuvant phase. And so this data also was just released and showed that event-free survival improved significantly with the addition of pembrolizumab, which again here is in the turquoise. So when patients only got chemotherapy, there was a 76.8% risk percentage of EFS versus 84.5%, basically meaning that there's a 7.7% difference in the chance that the cancer would come back, and it reduced that chance in the patients that had pembrolizumab. And then excitingly, overall survival data was also announced, and it showed that the addition of pembrolizumab also improved overall survival in this patient population. So the difference here was 86.9% with chemotherapy alone versus 89.7% with the addition of pembrolizumab. And again here, the same major risk exists, the risk of immune-mediated adverse events.
Laura, I don't mean to interrupt, but can you go back one slide?
Of course.
So although numerically the survival was improved, this is not considered a survival benefit. And it is really an interesting thing about how statistics are done in this sort of muddy way that is difficult for even people who've taken classes on it back in training. But here you can't see what the pre-specified p-value boundary is for approval, but it's 0.000. And here you have a p-value of 0.03. So although survival was a little bit better, not quite 3%, and there's less events, as you can see, about 4%, the p-value is not considered statistically significant. So this is not a significant difference in overall survival. The drug combination was approved based on what you showed earlier, which was the risk of recurrence.
And do you, Dr. Rugo, do you think that that overall survival benefit down the line will be more significant with more time to events?
Yes, I mean, I think you're already seeing a split there at 3 years. That's the 36-month checked, line there, vertical line. And what we expect to see is a continued difference, because if you go back to your event-free survival slide here, you can see that the number of events, and what do we call events? So they could be distant recurrence, it could be local recurrence, but for triple negative disease, it's really primarily what we're looking for is distant recurrence. And that will easily transfer into a difference in survival. It doesn't, one of the questions you always ask is, are you just delaying the development of recurrent or metastatic cancer? But here, if you look at the curves on the left-hand side, you have some patients who developed events early, and that's pretty similar in the two arms. But then once you get out to about a year, the curves separate out and they just stay separated. So it suggests that some people won't have a recurrence that could result in mortality or death. So I do think it's likely that we'll see a survival benefit. But, some women will also be able to receive a checkpoint inhibitor later. I don't know if you have that. Do you have that PCR data?
I don't have it in the slide set, but I can pull it up in a second.
So maybe Hope, while Laura's pulling that up, we can mention some of the other trials in this space where we talk about improvements in pathologic complete response and how that has been considered to be a surrogate marker for hopefully translating into better event-free survival, distant metastasis-free survival. And that one of the questions and challenges I think that we still face, even with this data, is trying to understand who needs the carboplatin, who needs the immunotherapy, who needs both, and who needs something else. And so I just want to throw that out there that, this is great. This is obviously a great advance, and we're hoping that we'll continue to, build on this advance by trying to identify, even better markers of which patients, not only are at risk of or developing, risk of developing immune adverse events is one possibility. And then also people that might get away without immunotherapy and people that need something different.
Those are such great points. And so just to amplify that, when we have cancers that we know respond to chemotherapy, we like to give treatment before surgery, so-called neoadjuvant treatment. And then if a patient goes to surgery and has no invasive disease in the breast or the draining lymph nodes, that counts as what's called a pathologic complete response. And patients, which Laura will show you in a moment, who have no invasive cancer at the time of surgery do very well. So the risk of recurrence isn't zero of metastatic recurrence, but it's really much, much lower than everybody else. So the idea is that if you do a new treatment, you could evaluate as a surrogate marker whether you have a pathologic complete response. And that could be true for lots of different treatments that we look at. And it's the basis of our multi-center neoadjuvant I-SPY 2 trial, where we're using this pathologic complete response as a surrogate marker. And here you can see that the PCR patients at the top did it really, really well. There's maybe a 1.9% difference, but it's not at all significant. regardless of whether you needed Pembro to get a PCR or you got it with standard chemo, you had a great outcome. But the patients who didn't have a PCR, so they had residual cancer there, if they got pembrolizumab, they had less recurrence events, which suggests that maybe immunotherapy is changing the environment, like the environment of the body, the host, the person, us, where the cancer is growing, to allow the body to be more of a sort of a guardian against the cancer growing back and to target those cells. So it's really fascinating, and we will see, oops, she went away. We will see more data on this I think at San Antonio, when we find out exactly what was going on with these patients who didn't have a PCR, but still seemed to do better if they got pembrolizumab. So I think that that's incredibly important. And actually one of the hallmark interesting things that came out of this trial was this issue of the patients who didn't have a PCR, who have a higher risk of recurrence, doing better if they got the checkpoint inhibitor. What Michelle also said, which I think is so important, is that it's really upon us, and we'll talk about the toxicities in a moment. There's a nice question in there about that for us to address in a moment. But, you know, we tend to add, right? So we're always adding and adding and adding, trying to improve outcomes. But some people will do really well with just less chemo. And this study also gave another chemo, carboplatin, that caused more nausea and low platelets and this and that. So the question is, maybe we could find some markers, and a lot of our colleagues are working on that, to understand who actually could just use standard therapy and do great, or who needs more with the checkpoint inhibitor. And that really relates well to what Laura's going to talk about now.
Thank you so much, Dr. Rugo, for that clarification. So in terms of immune-mediated adverse events, similar to the previous trial that I discussed in the metastatic setting in early-stage breast cancer, there was more toxicity with the combination of Pembro and chemo versus placebo and chemo. And so as you can see here with the teal bars, there was an increased rate of hypothyroidism, skin reaction, hyperthyroidism, and then some of the less common, but typically more severe IREs, so inflammation of the GI system, inflammation of the liver, that also increased. So the grade 3 to 5 toxicity, meaning the more severe toxicity rate, was higher in the Pembro plus chemo arm versus the placebo plus chemo arm. And so basically, this trial showed that the improved event-free survival rate was improved by 7.7%. Overall survival was improved by 2.8%, although, as Dr. Rugo pointed out, importantly, wasn't technically statistically significant. And there were more immune-related adverse events. And so really thinking in the future about which patients in particular would derive the most benefit from the addition of immunotherapy, and whether we can predict that in advance so we can see who might need to take this increased risk of toxicity to derive the most benefit and get that benefit. But based on data from this trial, the FDA approved pembrolizumab for high-risk early-stage triple-negative breast cancer in combination with chemotherapy as neoadjuvant treatment, and then continued in the adjuvant setting just this July, on July 26th of 2021.
That was great. Excellent review. One of the questions in the chat is, what is PCR and how do we know as survivors if we have it? So I don't know, Michelle, do you want to tackle that?
Sure. So PCR means pathologic complete response. And that means that when a patient who has gone through neoadjuvant chemotherapy or hormonal therapy, that when the surgeon goes in and takes out the tissue in the breast around where we thought they had cancer, that we don't find any cancer. And so this is something that patients can sometimes get confused about, because after surgery, we'll go over their pathology report with them. And for patients who've had a mastectomy, there's no residual, there's no breast tissue left behind, but what we're talking about is, what is left, what kind of tumor, how much tumor do we see, in the tissue that was removed. And sometimes these patients will have this panic look on their face when we talk about residual disease, and they're like thinking that we left it behind. And we're like, no, this is what we took out of your body. We're talking about what we found in the pathology specimen. So in the case of a mastectomy, they look through the entire breast tissue. In the case of a patient who has a lumpectomy, I think pretty much everywhere at UCSF and everywhere else, when you have a biopsy done of your breast, they leave a marker or a clip behind. And they're actually interesting that they have different shapes of clips, so that if a patient has 2 or 3 different suspicious areas, they'll say there's a heart-shaped clip or a rainbow-shaped clip or different. It's like little paper clips that they put in so that the surgeon can know where the tumor was previously. And so that's how the surgeon goes in and knows that they're in the right place, because oftentimes there is not anything left. There's no mass left. So the surgeon has to know where to go in to take it out. So they take out that tissue and they actually go in and they actually do x-rays to make sure that they have all the clips that they were looking for in the specimens. And then the pathologist takes it to the lab and, slices it up. And at UCSF and some other places also, there are several factors or several pieces of information that are given about that tumor that is in that tissue. One is the diameter, looking at it from one cell to the other. So you can imagine that a tumor started off like this big, and sometimes they collapse down so that they're tiny and they're like smaller, like a small ball. Other times they get like this with Swiss cheese appearance. And so another important factor when we're talking about residual disease is something called the percent cellularity. And it's actually almost a better situation if a patient starts with a 7-centimeter cancer and it shrinks down to 3 centimeters and what's left only has 1 or 2% cellularity, than if somebody starts with a 3-centimeter tumor and it shrinks down to 2 centimeters, but there's still a high cellularity. So all of those factors go in to this decision or determination of how much residual disease. And so pathologic complete response means we find no cancer in the breast tissue that's removed or in the lymph nodes that's removed. And then there's actually this gradation that goes something we call residual cancer burden. And this is something that's sort of unique to UCSF and other research institutions. So if you had your surgery somewhere else, you're not going to be told necessarily what your residual cancer burden is. But we're recognizing, as Dr. Rugo and Dr. Huppert said, is that one thing that might be happening with this immunotherapy is that we're driving patients, even if they don't get a path CR, closer and closer to a path CR. So maybe with a residual cancer burden of 1. And that is, that closer to getting a path CR is better.
So I think that's a great and a really nice and clear explanation. There's been some questions about whether clear margins mean PCR, but it's a very different question. Clear margins is good, but it does not the same as PCR, which is response to neoadjuvant therapy. So, but I think that cellularity is also a concept that I think sometimes people don't understand, but cellularity is the density of the cancer cells in the part that you took out. I think when you take out the tumor and you look at what's there, and there's very few cancer cells, that's low cellularity versus a lot more, which is high cellularity. So I think that, what we learned from immunotherapy is really important. And one of the questions was quality of life measured? And it seems like the side effects can be controlled well. I think that's one of the big issues that really led to approval this summer, as opposed to say 6 months earlier, was worrying about side effects. So I don't know, Laura, do you want to comment on that a little bit?
Sure. Quality of life was measured in these studies, and Dr. Rugo, you might know more about. I haven't seen that data necessarily.
It hasn't been set.
Yes, exactly. But we are learning to control more of these side effects. So typically, if you do have an autoimmune side effect, if it is severe, the most important thing is to stop the immunotherapy. And then to kind of cool off the immune system, we typically use steroids, which come with their own host of side effects if you need to be on steroids long term. But we are able to reverse many of these autoimmune side effects with the addition of steroids, or sometimes we also need actually other immunosuppressive agents as well. There is a rare risk, like 1% or so of long-term side effects that we can't reverse. These include things like type 1 diabetes or neurologic side effects that there isn't any evidence that steroids or other autoimmune type drugs or anti-inflammatory type drugs will reverse those conditions. So that is definitely a concern, something that's actively being studied.
Yeah, I think that, Michelle, I don't know if you want to comment about just briefly on toxicity, because I want to get to your section, but on side effects, I mean, the concern of the less in the metastatic setting, but these early stage data.
I'm sorry, can you, what was the question again?
Just to comment about your sort of take on the side effects, this toxicity, which is all immune related, and how that really impacts your decision making.
Yeah, well, I mean, I think that it cannot be understated that these, some of the immune, toxicities are very, very serious, and, they cause lifelong problems. Unlike with, chemotherapy, like, for example, as carboplatin causes a lot of nausea, more bone marrow suppression, fatigue, but usually, after patients get through that, they are through it and the symptoms go away and they don't have long-term sequelae of that treatment. But with immunotherapy, there are some long-term side effects. A lot of patients develop hypothyroidism. We've had, seen not so much in this study, but in our experience in I-SPY, so adrenal insufficiency. So patients end up having to take supplements, for their thyroid or for their adrenal glands, for a lifetime, which is something that, again, gets back to that, we can pat ourselves on the back about our successes, but we still have a lot of work to do to figure out which patients, need what therapy, because, there are other, side effects from immunotherapy that that are just evolving, effects on the heart that are rare, but could be very serious. And so I think that in the acute setting, these drugs have very few side effects, they're adding to pembrolizumab. Patients don't have necessarily, more acute fatigue or acute diarrhea. It's the consequences that happen down the road, and, including things like, liver enzyme elevations and things like that. So I just think we have to be respectful of the toxicities that can happen.
Yeah, I agree. And I think that just for the audience, I mean, what's interesting about immunotherapy, it's if you have knowledge about the toxicities and you have a high level of suspicion, patients can do fine. And they, unfortunately have to accept that in about 15% of the time, people are going to be taking thyroid medication for the rest of their lives. And in a small percentage, tiny percentage for most agents, but not all, you might need to take cortisol or steroid hormone for the rest of your life also, and wear a medical alert bracelet. So these are things that can happen. The rest of the things that happen are mostly reversible. So we treat with steroids, might delay treatment a little, but people get better. It's when you fail to recognize that something is an immune toxicity where it can become life-threatening. And it was felt in that study that 2 or 3 people died of immune-related side effects that were presumably recognized late, because I don't think we've really seen anybody in the last few years that's gotten anywhere close to being, dying of their immune toxicity. So it's just something that we have to keep aware of. I had a patient who got treatment with us, had a PCR, went back to her HMO insurance because she couldn't see us anymore, and had enormous side effects. Like about 3-4 months later, developed fatigue, inability to work, lightheadedness, felt terrible, lost 25 pounds. This went on for like 2.5 months. And then she ended up staying because she's friends with the son of a colleague of mine who's in primary care, who said there's something wrong. So we looked up her labs from the HMO, and she actually had this adrenal insufficiency, not peaking cortisol, but it wasn't recognized by her primary doctor or the endocrinologist because they didn't connect it to the immune therapy she had last gotten 4 months before. So this is the challenge that we have. So anyway, with that, it's very exciting to have a new treatment option for triple negative disease that can further help chemotherapy. We're hopeful that overall survival will be improved in the early stage setting. And we really need to improve what we're doing in the metastatic setting. We have some trials looking at just these questions at UCSF, where only 38% of patients are eligible in the metastatic setting to get a checkpoint inhibitor, these immune therapies, and have the benefits. So what we need to do is try and encourage the rest of the cancers to be more sensitive to immunotherapy. So with that, I'm going to hand it over to Michelle to talk a little bit about the endocrine therapy improvements that we're making in metastatic and early stage disease.
Okay, give me 1 second so I can share my slides. And I was wondering if we wanted to address the question about, before we leave the topic of immunotherapy, can we retreat immunotherapy if patients develop immune-related side effects? So I haven't actually done that, Hope. So in the metastatic setting, I mean, I think in the early stage setting, we tend not to want to do that because usually the patients are finishing up their therapy by the time we realize they have it. But do you want to?
We do treat through hypothyroidism, hyperthyroidism, and adrenal insufficiency. We treat through the endocrine side effects because we can treat the endocrine side effects. For other ones, we hold drug, but one area where people have retreated has been where patients had a rash. And if you retreat and the rash doesn't happen, you're okay. The rest of it, it really depends on the severity of the side effect. So it's individualized. But we better go on to.
Yep, sure.
Yeah.
So I will go ahead and share my screen. And so now we're going to shift gears a little bit. I'm going to move this over so I can start from the beginning for the slideshow. And so we're going to talk now about some endocrine therapy trials, one in the metastatic setting and one in the early stage setting among high-risk populations, but they both deal with the same class of drugs, the CDK4/6 inhibitors. And for the sake of time, I won't give you, that was an awesome biology lesson that Laura gave us for the immunotherapy. But the CDK4/6 inhibitors, they stand for cyclin-dependent kinase 4/6. And apparently it turns out there's lots of cyclin-dependent kinases in our body that are involved with movement of tumor cells and cancer cells and regular cells through the cell cycle. And so this class of drugs inhibits a subset of these cyclin-dependent kinases, resulting in changes in tumor cell growth and growth in other cells. So the Mona Lisa trial was one of many trials that have gone on investigating this class of agents, the CDK4/6 inhibitors, both in the first-line treatment of metastatic breast cancer, the second-line treatment, and then we've also been involved in trials looking at these agents third-line and beyond. It enrolled postmenopausal patients that were hormone receptor positive and HER2 negative. This trial included those patients who had no prior therapy for advanced disease. Patients that had prior either adjuvant or neoadjuvant endocrine therapy were allowed. And patients were randomized to receive the standard at that time treatment of an aromatase inhibitor, letrozole, or the CDK4/6 inhibitor, ribociclib, which is given in a schedule of 3 weeks on and 1 week off. And the trial was looking at a number of endpoints, including progression-free survival, as well as overall survival. And so to put this, this data that I'm going to show to you into context, I mentioned that there are many agents in this space, 3 different CDK4/6 inhibitors, including Ibrance or palbociclib, Kisqali, which is ribociclib, and then Verzenio, abemaciclib. And this table shows you the different studies that have been done in the first-line setting with these various agents. And I want to point out to you how remarkable it is that if you look here at this data on progression-free survival, looking at the hormone therapy alone versus the hormone therapy plus the CDK4/6 inhibitor, the numbers are just amazingly close in terms of how well patients do on the single hormone therapy arm versus the CDK4/6 arm. And so when patients ask me, how do I choose in the first line setting, whether to give a patient palbociclib, ribociclib, or abemaciclib, I basically say it really comes down to, in some ways, personal choice and our comfort with one drug versus the other, and then the side effect profile. But what this trial that was presented at the update at ESMO really focused on, I'm going to move this around now, is the ribociclib, the Mona Lisa 2 trial, again, which was in patients with first-line metastatic disease and compared ribociclib plus letrozole to ribociclib plus letrozole alone, and they presented the overall survival data showing that there was a 12.5-month improvement by adding this agent to letrozole. And so looking out here, you could see the patients that got the combination, the median overall survival was out here at 5.3 years. And the patients that just got hormone therapy, it was just over 4 years. I want to point out here, though, for those of you in the audience with metastatic disease, is that that there are definitely patients that are still living longer, and out here, close to 7 or 8 years, we're still seeing a good number of survivors. And you have to recall that this data is now over 6 or 7 years old. So I want to stress that these patients that started on the study were diagnosed, 7 years ago or 6 years ago with metastatic disease. And so we're, optimistic that we're going to be even doing better in patients with metastatic disease at this time point, because we've had a number of new agents that have been approved. For example, alpelisib for patients with PI3 kinase mutations, and then other drugs under development like oral SERDs and other androgen or estrogen and androgen blockers. One thing that was very nice to see is that with longer periods of follow-up time, that the survival benefit was continuing to increase. The difference between the two, meaning patients that got hormone therapy only versus the combination, continued to grow over time. And so that's reassuring that maybe even if patients didn't get an initial benefit, with a significant benefit with adding the CDK4/6 inhibitor, we're still seeing improvements in overall survival further out. And so what do these drugs, what did this class of drugs cause, specifically with the ribociclib? Notably, the median duration of treatment was 2 years with a combination versus 1 year with hormone therapy only. And with over 80 months of follow-up, so over 6.5 years, they did not identify any new toxicities with this class of drugs. As you can see here, the main side effect or the main toxicity we see with ribociclib, as well as with palbociclib or Ibrance, is neutropenia. We also see something called hepatobiliary toxicity. So this is manifest by elevations in the liver function test, and this was significantly higher in the combination than with hormone therapy alone. And then the other thing I want to point out is this entity called prolonged QT interval. And I bring this up because I think it's important as people are interested in participating in clinical trials. This has come up as kind of a big deal for eligibility for trials, in that we are recognizing that more and more drugs have an impact on the way that our heart beats, the way that the electrical signals are conducted through our heart. And so there's an entity called the prolonged QT interval, which puts patients at risk for having a more severe arrhythmia. And some of our common drugs that we use all the time in oncology, as well as some of our antidepressants, have a tendency to lengthen this QT interval. So I just throw that out there as something for patients who are looking for trials to be aware of, because there are times where we've actually lined someone up for a trial and then found out that they are on a drug that is no longer allowed because of it prolonging QT interval. And then the last thing is something called interstitial lung disease, which happened rarely, but is also a complication that we're noting with several of our other agents, including one that Dr. Rugo is going to talk about later. Moving on for the sake of time, the next trial that I'm going to be talking about is the monarchE study, which is with the third of the CDK4/6 inhibitors I mentioned earlier, a drug called Verzenio or abemaciclib. And this trial was designed for patients who had high risk disease, so early stage breast cancer, hormone receptor positive and HER2 negative, and they could be considered high risk based on their clinical or pathologic features. So this was cohort 1 here, where patients had either greater than, the ALN stands for axillary lymph nodes, so having 4 or more axillary lymph nodes involved with cancer, or they could have up to 3 lymph nodes, but they had to have either very high grade tumors, so grade 3 tumors, or a tumor size greater than 5 centimeters. They also looked at another cohort of patients where they considered them high risk based on something called Ki-67, which is a measure of the proliferation of the tumor. And so we think of that as a marker also of risk. And so patients were randomized, these 2 cohorts were randomized. This is a very large study of over 5,600 patients to receive either the standard endocrine therapy that their oncologist thought they needed to take after diagnosis of this early stage breast cancer. So after completing chemotherapy, radiation, patients we put on tamoxifen or an aromatase inhibitor, And then they were randomized to that or either that plus abemaciclib given at a dose of 150 milligrams twice a day. And what they found was that, so this term IDFS stands for invasive disease-free survival benefit. And what they found here is that with a follow-up time of 2 years, the rate of patients being free of an invasive recurrence with the combination therapy was 92.7% versus 90%. So a 2.7% benefit by adding this abemaciclib. And then with longer follow-up time, that benefit actually expanded out to 5.3%. So there had been some concerns when this data was initially presented that it was actually premature to show the data that actually with longer follow-up time that these separations might come back together. But we actually see, I misspoke, it's actually 5.4% difference. So we actually see the curves spreading farther apart rather than coming back together, which is very reassuring. And then this term here, DRFS, stands for distant relapse-free survival. So the spread of the cancer to another part of the body. And at 2 years, you can see the difference between these curves was about 2.5%, but at the 3-year mark, it was actually spread out to 4.2%. So again, very reassuring that we're seeing a further separation of these curves when given the abemaciclib. And so for the sake of time, I'm not going to go into the slide except to say that you can see here that something called the hazard ratios, which is a marker of like how much better there is a further risk reduction, seemed so getting lower, a lower hazard ratio means a better improvement. And we could actually see that that over time, that out at 2+ years of follow-up time, that the hazard ratios continued to get smaller. And so then they also looked at this subset of patients that had this marker, the high Ki-67, which I mentioned before was this unique cohort where we think that this is a group of patients that have higher risk, but they may not have a traditional marker like having greater than 4 positive lymph nodes. And similarly, they found that, again, the magnitude of benefit was increasing. And out here at 3 years, they actually saw a 6% difference in this population of patients that had a high Ki-67. So identifying a unique population of patients with high risk early stage breast cancer that could really benefit from this intervention by adding the abemaciclib. And so I'm going to move on for the sake of time, just to move on to the safety data. So what do we see? What does this cost? Well, there is a significant amount of diarrhea with the addition of abemaciclib. And you can see here that these bars show that basically 84% of patients that received the abemaciclib or Verzenio had some level of diarrhea, as compared to only 9% in patients that had endocrine therapy only. And so the majority of the diarrhea is grade 1 or grade 2, but it's still fairly significant and it definitely impacts people's quality of life. Similarly, there was an increase in fatigue, as well as an increase in neutropenia, abdominal pain, nausea. Interestingly, there was fewer hot flashes than arthralgists noted, which I think is because patients were dealing with other side effects. So they weren't noting the usual things that patients normally comment on or are troubled by when they're taking hormone therapy alone. There was also more anemia, as you can see here. So I'm going to finish up there and stop sharing my screen. But I think this is really exciting because, we are trying to continually improve and try to find ways to reduce the risk of recurrence in these high-risk ER-positive patients. And when the data was first presented and Lilly, the maker of Verzenio, did the press release, we were excited but concerned because we thought the follow-up time was short. And now with longer follow-up time, we see the data is holding up. And as a result of this data, that this drug was FDA approved just a few weeks ago, I believe, for the treatment of high-risk ER-positive, HER2-negative patients in the adjuvant setting.
Michelle, last week.
Last week. Oh, I thought it was a couple. Time goes by fast. I thought it was 2 weeks ago already.
It was less than 1 week ago. I actually think it was on Thursday, the day.
Was it? Okay, time flies.
And it is fascinating, and I think that was such a nice description of the data that we have. This Ki-67, which is a marker of cell turnover, like how fast the cells are turning over, we refer to as proliferation, is a marker which has been dogged for decades. Everybody says it's not reproducible, you shouldn't do it. And it was like withdrawn from all the pathology testing that we did. And then there were all these people who worked on harmonization of Ki-67, like if you had 20 pathologists looking at the same sample, how much did they say it was the same? And there was like a 50-50, it wasn't good. So then they developed criteria so that people could actually be have more reproducible calls. For Monarch E, that you actually had to send the tumor from the patient centrally to a central place where they would do the Ki-67 and tell you if what you had done locally was right or not. We had one patient who had a Kaiser high Ki-67 was not high when they looked at it. So I think that, there's some variation. So the fact that abemaciclib improved the outcome, as you could see in the whole population, but greater in patients who had this more proliferative disease, the fact that the Federal Drug Administration used that for the approval was shocking, actually. And we had, Twitter storm about it because, that was really so surprising to use a marker which isn't commonly used in order to determine who could be eligible for abemaciclib. So I'm hopeful that over time, the FDA will relax that, because I think that it's maybe not right. If you had 4 positive lymph nodes and a Ki-67 of 18%, based on the FDA approval, you don't qualify for abemaciclib, and that makes no sense to me at all.
Yeah.
So I hope with longer term follow-up, it makes a difference. There is a question just to ask you, Michelle, is and we want to get to Shagun, and I'm going to just show the one curve from the Destiny Breast 03, but if a patient didn't tolerate the diarrhea with abemaciclib, would you consider switching to palbociclib if patients tolerated it better despite the PALLAS data?
No, I would not. I think that we can dose reduce the abemaciclib, and it's made a tremendous difference. So the dose that was studied was 150 milligrams twice a day. And it is amazing how much better patients do if we drop it to 100 twice a day. So, and we didn't show the dose reductions that occurred in this trial, but I think that it would favor doing a dose reduction, which is often very well tolerated, rather than switching drugs, because the PALLAS data didn't actually show a benefit with longer follow-up. I don't know if others feel the same way.
Yeah, I think I did use both palbociclib and ribociclib, and we participated in the ribociclib trial,
Okay.
which is now which is now closed to enrollment. But PALLAS enrolled a slightly different population of patients, but we can only, as physicians, carefully looking at data, look at the data we have, and the data we have doesn't say that palbociclib helped, whereas abemaciclib did, and it's approved. So unless it's a study where we're looking at ribociclib, and ribociclib certainly has survival data in the metastatic setting, I agree with you 100%. I think dose reducing and taking a half an Imodium every day and changing your diet a little bit for 2 years where you don't eat, large amounts of raw vegetables helps a lot. It's just a pain for patients. And I think, managing it over time, I think does work, as you commented. And then, one last question. We got to get Shagun in there, but how do you gather, I have to ask this, and Michelle, how do you gather patient-reported side effects? Is it gathered from a list, patients prompted with a set of possible likely side effects, or is it open, any possible side effects could be reported?
Yeah, it's a great question. And that's actually a moving target, because, for most clinical trials in the past, the side effects were gathered largely from the clinician reporting. So at the end of, I would see perhaps like a patient on a trial, and a diligent study coordinator, scours through my notes and, writes down, what I said, or picks out from, what I said about the patient having a rash or diarrhea or, X, Y, or Z, and basically pulls out anything. And so it's not really from a list. But as you can imagine, this is quite imperfect, because we talked about grade 1 versus grade 2 diarrhea. Well, there's a discrete definition of what grade 1 diarrhea is, which means, more, up to 3 bowel movements a day over a patient's baseline. Well, I mean, I didn't, prior to, participating in trials, I didn't ask patients whether they had, their baseline was 1 poop a day or 2 poops a day. But now you have to, because if a patient has diarrhea 4 times and their baseline is 1, then that's grade 1 diarrhea. But, it depends on where a patient's baseline is. And if you actually write down in your note how many episodes of diarrhea, and this is also flawed because, a patient, is having diarrhea and they can't tell, like they often forget how many times they go that day. It's like, seems like 10 times. So there's been a movement towards, first of all, trying to create very discrete lists of toxicities. And Dr. Rugo has been leading this in our I-SPY trial so that we don't have all these random side effects, that we try to be very concise about naming a side effect. And then also there's an interest in collecting patient-reported outcomes in addition to clinician-reported outcomes to see how these compare, because one patient might have 4 bouts of diarrhea a day, but it doesn't bother them, and another patient could have 4, and it could be life-changing because they can't go to work. So there's this whole idea about side effects and what's called interference, in addition to frequency and severity, is how much does this interfere with your life? And I think it's something we're very interested in, merging these 2 ways of collecting adverse events in trials.
Yes, and actually Michelle is a co-chair of the patient-reported outcomes working group as part of our multi-center consortium throughout the United States. So she has playing a big role in how we're thinking about patient-reported outcomes. And then I want to go to Shagun, but I'm going to show you one curve, which is like such a big thing for us. Let's see here, sharing. Okay, let me see if I can get this out here. Show you here. Let's say share. Okay, so everybody can see this. Can you see this? Yes?
Yes. Mm-hmm.
Okay, good. So this is a really big word, trastuzumab deruxtecan, but we call it TDXD. And this was a study done in patients who have HER2 positive metastatic incurable breast cancer. And they compared trastuzumab deruxtecan to TDM1, also known as Kadcyla. These drugs are called antibody drug conjugates, and they have an antibody against HER2. This one is Herceptin. This one is a biosimilar for Herceptin, trastuzumab biosimilar. And then you can see all these little circles. They have a payload, a toxin, a chemotherapy that's attached with a linker onto the antibody. These are called antibody drug conjugates. They are smart bombs. They deliver the toxin directly to the cancer cell that we know is HER2 positive. And we have other drugs like Trodelvy, sacituzumab, which is another antibody drug conjugate approved for triple negative disease. So it's an explosion in new treatment that seems to be highly effective and relatively well tolerated. Everything has its side effects, and these drugs are rapidly moving into the early stage setting. So that's why it's so important to mention them, because this is not just against HER2 positive disease, it's broad reaching. So this trial randomized patients who had prior trastuzumab, Herceptin, and a taxane for metastatic disease, and only a portion of them had received prior pertuzumab, and they were randomized to get TDXD or TDM1 1-to-1, and then they looked to see what happened to the patients. And you can see that they had a little more than 500 patients. And then in terms of which patients had pertuzumab, it was about 60%, so it's very reasonable. That's listed here. But I just want to show you this curves here. So this looks at progression-free survival. So how long were you on the drug until your cancer started to grow again? This is unbelievable data, right? I mean, we almost never see anything like this. Trastuzumab deruxtecan or TDXD was enormously better than TDM1 in terms of controlling the disease. And you can see that the number of patients whose disease hadn't grown at 12 months was 34% for TDM1 and 76% for TDXD. And this p-value is times 10 to the minus 22. So it's pretty amazing. We just don't see that. And everybody benefited. They couldn't find a group of patients where you see these little circles all lined up. It means that all of these different categories of patients, even those with brain metastases, all benefited more from TDXD than from TDM1. It doesn't mean that TDM1 doesn't work. It just means that TDXD is better, and everybody's tumors shrunk also who are on TDXD. Now, as Michelle was mentioning, pneumonitis or inflammation of the lung has been a big issue, and there actually were a few patients who died of pneumonitis with TDXD in the earlier trials. Here, they had no one die. dying is grade 5. 0 people died, but you still saw some. And what they do now is discontinue drug permanently if you have symptoms associated with pneumonitis. If you don't have symptoms and you just have some changes on your x-ray, we hold the drug and give some steroids. And that seems to have prevented these really scary side effects. The heart does fine. So this drug is approved for the treatment of metastatic HER2-positive breast cancer, but most excitingly, even in addition to this fabulous data, is that it seems to work for cancers that aren't HER2-positive, largely hormone receptor positive. They're so-called HER2 low. So HER2 is 1+ or 2+ on the pathology report, but not HER2 positive. And that data we should see next year. We've seen incredible responses of long duration with this drug in patients who have HER2 low, not HER2 positive disease. So that's the future of this drug, and it's really exciting. So I just wanted to briefly share that with you before we move on to Shagun, who's on now. You are on mute, Shagun.
Give me one moment trying to get the share screen going. Let's see. All right. You can see my screen?
Yes.
All right, great. That was some really amazing curve difference there, Dr. Rugo. Thanks for showing that data. And I'm excited to follow up these two really great presentations. Thank you so much for the invitation to speak with you all tonight. And I look forward to discussing COVID-19 topics and topics as it pertains to persons with breast cancer. So this little New York Times article may give you a little bit of flashback from March 12th, 2020, when the New York Times declared this COVID-19 as a pandemic, which was rapidly spreading. Physicians at this time were sharing information hour by hour. We were really learning by the day and did not know what to anticipate, which gives, I think, doctors a lot of anxiety. Typically, we work in a world where we have been able to build on our knowledge as the years have gone by, but with COVID, we were all learning together. As patients were suffering from it, we were suffering from it, and really trying to understand how to best help care for our patients. I think important for us to just pause and think about what sort of changes happened early in the pandemic. Telemedicine really became an option and seems to be here to stay, which I hope that patients are liking it. I really like it. It's really changed the way that we practice medicine and the availability, access to care. Appointments were, of course, delayed. Elective surgeries were postponed. I'm sure several of people on this call experienced things like that. Screening tests were delayed. Administration of IV supportive care medications, such things like bone-directed therapies, were likely delayed. Really importantly, clinical trials were put on hold, and this was very scary for some time. And of course, cancer treatments were modified, hopefully to help minimize patients from exposure to the virus by coming in and out of hospital systems. So I'm going to start by discussing, of course, the state of the pandemic currently worldwide in California. On the left here, you'll see that worldwide cases are truly decreasing. This is that data from here in October. And on the top right, you can see that overall cases of hospitalizations and deaths are decreasing. In the USA, most of the states that are showing a decrease in cases are those that have the highest amount of patients who are people who are vaccinated. Now on the bottom right, just a nice timeline of what's going on in California. It's where you can see our most recent wave didn't have such a high peak, but it definitely is downtrending. And I always like to talk about how things are doing at UCSF itself. So these are just the two boxes that I'll talk about. This box on the left, you see that the case positivity rate for people, I keep saying patients, but sorry, these are all people who get tested. Those who are symptomatic and are getting a COVID PCR, the positivity rate is pretty low, 3%, not bad at all. And those who are asymptomatic, our rates are now less than 1%, which is where we need to see it. So people who are getting tested for things like procedures or surgeries, about 0.6% of those persons do test positive by PCR. Admitted in the hospital these days are 8 people right now who are in the acute care setting and 7 in critical care, with 6 of them being vented. And I'd like to show this right here, that the case positivity rate daily for patients hospitalized. You can see overall things are trending down, but look at how low we were up here from January to April. We really flattened that curve down here in April, and we haven't achieved these values yet, and that's really due to the Delta variant. So talking a little bit about the variants, the CDC defines 3 different groups of variants: variants of concern, variants of interest, and variants of high consequence. The Delta variant is considered a variant of concern. It spreads more quickly, unknown if the disease it manifests is more severe, and especially in the world of vaccines, we don't know, would it be more severe without vaccines? It makes antibodies modestly less effectively, and we'll discuss vaccines in general a little bit later. I want to show here that the Delta variant really is the predominant COVID-19 variant in the United States and truly in the rest of the world as well, as shown here in this color. This is at UCSF. Anyone who tests positive, their PCR sample is tested to assess what variant it is, and most cases are of the Delta variant. So how is the Delta variant different? There's a couple of things that make it different. First of all, there's 3 mutations in its receptor binding protein, which makes it stickier, and antibodies can't recognize it as easily. Antibodies that the body has, which should recognize the virus and try to kill it, just simply cannot. There's a mutation in this cleavage site and a mutation in another super site, which kind of makes it more invisible, so antibodies can't detect it as easily. And as we already know, it's more transmissible and contagious. It is 60% more transmissible than the Alpha variant was, 200% more transmissible than the original Wuhan strain was. And the viral loads when people are infected with the Delta variant, especially those persons who are unvaccinated, appear to be 1,000 times higher. And as the New York Times quoted, it is as contagious as chickenpox. I really like this. I think you should go back and look at this from the New York Times article on July 30th, 2021, showing all of the different infectious viral diseases in our world and where the Delta variant sits as compared to the others. So just in summary, this is just a quick summary slide about the variants, about different types of variants. Luckily, as of October 2021, it appears that the Delta is dominating the world without other known concerning players, but we'll learn as time goes on if there are new variants that come up that we need to be thinking about this virus differently. Just a quick little information about testing strategies. Just as you probably all know by now, there are 2 different types of tests that we can look for COVID. First is a viral test. So that's when you get the swab in the nose. At UCSF, we've really learned that you don't need to go as far back as we used to. And so it's not as painful of a test. So there's a viral swab test that is normally done via PCR. And then there's a blood test, an antibody test. This blood test looks for past infection or vaccination status. It is a simple test. It's IgG based, and it looks for whether or not there's a production of spike proteins or nucleocapsid. And I'll talk about the difference between both of those in just a minute. This is, I'm just going to skip this in the interest of time. What we should know about blood antibody testing, there's 2 types. The nucleocapsid really detects past natural infection, and spike test can detect past infection or immunity from the vaccine by an antibody. Important that we don't use these for diagnosis, and I really want to point this out as I talk about vaccines and titers, is that it's unclear how we interpret the quantitative or the number of the titer information, and there's different titer results across the country based on different labs. None of this has really been validated. We don't know what titer value equals protection. We don't know if higher titer means that protection is better either. There's some people say yes, some people say that we just don't know, and I think we will have to continue to learn, and hopefully the next time I hopefully come back to talk with all of you, we'll have more information of this, because I really want to understand this better too. So just a quick summary about testing strategies. Testing is an important part of mitigation efforts for us. So I think that anytime any of us become symptomatic, regardless of how mild the symptoms are, in order to try to prevent the spread of COVID, we all need to be getting COVID testing. Viral testing should be done with anyone with symptoms and for exposures as well. I want to point out that if you've been exposed, have a high risk exposure, and that is currently defined by the CDC as being within 15 feet of somebody who's known to have COVID for, 6 feet for 15 or more minutes, it's considered a high risk exposure. The viral test can currently detect all the variants of concern, and antibody test can detect past infection or a response to the vaccine, but truly they don't tell us the full story. All right. Hot topic of the COVID vaccine itself. Well, what about the efficacy of the vaccine in persons with cancer, namely the group of patients we care for and all of you in the audience this evening? There's a lot of great information out there about the efficacy of the vaccine, and especially the studies that were initially done, but they only really included persons who were immunocompetent. So the immunocompromised host was not included in those vaccine studies. And I really liked this letter that was published in Cancer Cell called Care Without a Compass, including patients with cancer and COVID-19 studies, where the authors put on paper what we're all thinking, advocating for you to ensure that you're included in studies looking at the efficacy of the different aspects of COVID-19 care in a person with cancer. Because what it seems like we're doing is trying to play catch up a lot for persons who are immunocompromised, since not being included in initial studies means that we don't actually know what the outcomes are for persons who are immunocompromised. Luckily, though, because of such great advocacy, there's been pushes to be able to treat persons who are immunocompromised with the drugs and faster than those who are immunocompetent. This is a nice chart by Monica Gandhi. I'm sure you're all following her on Twitter. She puts out a lot of great information and is the most up-to-date source, I would say, about COVID-related matters, about the three different, I want to point out the three different COVID vaccines that we really use here in the United States and show you that the efficacy of the COVID-19 based upon different clinical trials. The data showed that all of the vaccines produced very strong antibody responses, and they also did produce T-cell responses. Again, just pointing out that these were in persons who are not considered immunocompromised. The studies did not include people with cancer. The yellow column shows that there was excellent production against excellent protection against severe disease, as defined by requiring hospitalization. Of course, we all hoped in the beginning of the vaccine that we would no longer get infected with COVID, but what we have now learned is that unfortunately we will probably, if you have an exposure, you might get infected with COVID, but hopefully with the vaccine, the intensity of your infection will be much, much decreased and you will not require a hospitalization, which I would say, is by itself very promising and something that we likely will have to live with. I'm going to skip this slide as well and just go to this data right here showing the incredible efficacy that these are the original publications for both the Moderna vaccine, mRNA, and the Pfizer vaccine over here. Both of these are mRNA vaccines showing that persons who got vaccinated at the bottom lines, the rate of having symptomatic COVID infection was much, much decreased. And I think that I want to point out that through this talk, I'll be talking about two different responses. One is what is the antibody response, which gives us a little bit of information. And second, though, which I think is probably more important, is how many people actually get infected with COVID and how severe the infection. And those are different things we're going to really see as trials and studies come out in the coming months and years, that there will be two different things that people are looking at. And so just keep those things in mind as you're reading data, because antibody response, again, the blood level of the spike antibody is only one portion, but what is probably more important is how sick do people become, and hopefully how sick they do not become. So our vaccines, how do we determine the effectiveness of the vaccines? There's so many factors that come into play. There's demographic factors, so how much virus is circulating in a community, how close do you live to somebody, how many people are vaccinated, vaccine factors, which vaccine is used. I'll show you some data regarding that. The number of doses, the timing between doses, of course, a hot topic, heterologous vaccines, which is the mixing and matching thing, which Twitter was on fire with today. Immune factors such as, can the body mount an antibody response? Viral variant factors such as the increased transmissibility, as we have learned to exist currently with Delta, and of course the person who may be exposed or who is at risk for getting COVID. Older age, we know, definitely, unfortunately, puts someone at high risk for getting COVID and for unfortunately having poor outcomes, as we learned from Colin Powell this week. Previous infection potentially is more protective, and a couple of other different factors as well. Of course, having cancer and being on cancer-related therapies. What do we need in the time of Delta? Real-world observational studies show that there is possibly decreasing vaccine effectiveness against the infection. So this is what I'm pointing out again, that maybe we might get infected with COVID, but this last line, there's clearly protection against hospitalization and death. This remains excellent and robust, even in the time of Delta with vaccines. And I wanted to also mention, just focus on this right side right here, that in a population of patients in LA, the infection and hospitalization rates against unvaccinated persons as compared to vaccinated. Unvaccinated persons had 5 to 30 times, were 5 times more likely to get infected and 30 times more likely to be hospitalized as compared to those who are fully vaccinated. So I hope that everyone listening on the call today are fully vaccinated. I have to say, a couple patients in clinic this week, they had not been vaccinated, and I really pushed them to get vaccinated. And I was happy to read messages from them today saying that they did go to their local Walgreens and get their first dose of vaccine. So I feel like I had a good week this week by getting a few folks vaccinated. So next, regarding vaccines, there's so much to talk about. There's a lot of information out there that not a lot is really greatly data driven, but I will talk with you about the information that I found interesting right now. And of course, this stuff is going to get better. So talking about the third dose, who should be getting a third dose, why we should get a third dose, boosters, and of course, mixing and matching vaccines. So the FDA approved a third COVID vaccine dose for certain immunocompromised individuals. So that's different. There's a difference between what we're calling a third COVID vaccine dose and a booster dose, and the reasons why we recommend it. So here's a definition of them. A third dose is the FDA recommended a third dose to persons who were immunocompromised as part of the primary series of vaccination when the initial immune response was likely to have been insufficient. So the group of persons that I think who should get a third dose probably are those who are currently undergoing cancer fighting treatments. So if you're currently on treatment or you have been within the last year, and that's treatment like chemotherapy, I do think that you're probably considered immunocompromised, and it makes sense to get a third dose of the COVID vaccine. There's also now the booster dose, which is a supplemental dose to give into people who we think the initial immune response was probably sufficient, but maybe waned over time. And this is really about the numbers of the antibody. The antibody titer may have been great initially when it was given, and maybe it decreased a little bit in time. And the FDA approved boosters for those who are more than 65 years of age, along with other categories of people. Here's a little bit of data. We're talking about the rationale behind the third vaccine dose for the immunocompromised person. What we know about the immunocompromised person, and I work in the world of hematology mostly, so my patient population are the most immunocompromised when you really look at patients who are on immunocompromising types of treatments. When you compare solid organ malignancies, which breast cancer is in, versus liquid malignancies, which is what the world that I really work in, versus persons who have solid organ transplants and are on immunosuppression. And then, of course, there are people who have rheumatologic disorders who are on some therapies which can make them immunocompromised as well. So the immunocompromised host is more likely to get severely ill. They are more likely to have prolonged shedding of the virus. So at UCSF, when somebody is immunocompromised and gets COVID, we really recommend a 20-day quarantine period rather than 10-day, which is recommended by the CDC for immunocompetent people. There's been some thought that because the immunocompromised host may have prolonged active viral shedding, they may have an increased risk of developing viral evolution, and that's where we get the different variants, and it may occur faster in immunocompromised persons. They may develop lower neutralization titers, may transmit it to household contacts, and really the goal is to improve the immune response among immunocompromised persons in whom the primary vaccine series may be insufficient. And here you can see on the right, this was a group of solid organ transplant patients who, before the third vaccine, you can see that their titer value of the spike antibody protein was low, and then after was higher. And then patients who had placebo, of course, did not have a higher value of a spike antibody response, just showing that the third vaccine increased at least the antibody titer in the blood.
So Shagun, I'm just going to interrupt. I'm sorry.
Sorry.
To say, because we're sort of running out of time, we could talk about this, I think, for the whole session, but there were some interesting questions in the chat about in the Q&A. One was the CDC at this time says at this time, based on available studies, having a history of cancer may increase your risk. What are the details of these studies? Does it indicate you should get a booster? If somebody's just on hormone therapy, they're not immunocompromised. And then just if you can answer, if you got the J&J dose, should they only get the J&J booster, or can they get Pfizer?
Let me answer that question first, based upon the most recent data that was just published about the heterologous types of vaccines. So first, we don't know about Pfizer versus, with another dose of, we don't have a lot of great information comparing mRNA followed by more mRNA. But this study that was just published October 17th, which is now by the FDA, has now approved heterologous or mixing and matching of vaccines, compared people, so all persons, and there was a small percentage of people who did have cancer as well, getting an AstraZeneca vaccine followed by Pfizer versus AstraZeneca followed by Moderna versus 2 AstraZeneca and AstraZeneca. And what they found was that in this population of patients, it reduced symptomatic COVID infection by upwards of 80%. So less people got COVID infections when they had a J&J-like vaccine or an adenovirus. In this one, it was AstraZeneca, followed by the mRNA. The FDA has now approved this, and so you can go get another vaccine. I do think we need to let the pharmacies catch up to this. I'm hoping that they'll be ready. They were ready for this and it will be available tomorrow, but I don't know that for sure yet. But
so
it does make.
Shagun, if you got J&J, because nobody will have gotten AZ, then they could get a Pfizer vaccine and expect that they might even have better boosting of their immunity. And then what do you think about having a history of, because I don't understand that. We didn't really see that having a history of cancer increased people's risk, but it is a comment by the CDC.
Yeah, I think that it's really vague what the CDC says. And so I think we all have to think about what we consider as a person being immunocompromised. My stance on it is that if you're having, of course, if you currently have cancer, that's one group of patients who are clearly immunocompromised. If you've developed cancer or were actively treated for cancer within the last 1 year, and I mean treatments such as chemotherapy, probably considered immunocompromised, but greater than 1 year ago and you're considered in remission or even cured, and even if you are only on hormonal therapy, which I have some slides showing that even people who are just on hormonal therapy actually have a great response to the vaccine, and I would not consider them immunocompromised.
That's really great and very helpful. And then another question, just as we close, because we're a little 1 minute over time here, that outside of the medical field, any tips for how we reinforce the seriousness of masking? Should we be wearing masks? Obviously, we're wearing them in a medical setting, but what about in the business community? And what about, testing? And should people be tested every week? And, when people come here from other places, in the States, and they're like, wow, everybody's wearing a mask, So what should people feel comfortable with? I've had a lot of patients say to me, I have a wedding to go to on the East Coast. Everybody has to be vaccinated to go to the wedding, but we have to take off our masks to eat. So is this safe? Should I do that? What should we do?
First, there's this great website called www.microcovid.org, which I think helps us assess risk of COVID in the community. And you can put in different factors of people masked or not masked, or how many people are going to be there. And there's a lot of different calculations which can help us understand what is considered low, medium, or high risk. Dr. Rugo, that's a hard question, right? And I do think that everyone has to kind of think about what is considered risky for them. If you are actively on some type of cancer fighting treatment and you're going to be in a big crowd where everyone's going to be unmasked, I probably would recommend that you keep your mask on. I don't want to tell persons to not go to family type events, but you might want to be more protected and keep your mask on, even as uncomfortable as that is.
Yeah, that's really interesting. And I think, but it does mean that you could go to family events. Most of these patients are triple vaccinated. So it seems like it's reasonably safe to go to these gatherings. It's just, I think, again, I think Colin Powell made everybody a little anxious, but he had a disease you treat, multiple myeloma, where you just don't have good B cells, right? So
exactly.
You don't have the cells that make the antibodies, that's a whole different thing than breast cancer. So I actually think your comments have been fabulous and really helped our understanding and thinking about this. I love the microcovid.org website. That's great. And I think really helpful for our patients and for people who are on. We've run out of time, and I want to make sure that we respect the timing, because I'm so grateful for our speakers today, Michelle Melisko, Laura Huppert, and Shagun Arora, and for, of course, Melody Gaulu, who is really done an incredible job of keeping this organized and going and making the forum happen. And I see that Shagun is showing this really very cool data about CDK4/6 inhibitor therapy, that people had lower titers. And that's, the one thing I will say, which I heard at a recent grand rounds, is that the titers are not necessarily the best indicator of our immunity, that we've got several aspects of immunity. So it's really hard to know. The T cells are also important, as well as the antibodies. So now we haven't actually seen bad disease in people who've been on CDK4/6 inhibitors. So I think that that's an indication also. So I definitely want to thank everybody. We don't know exactly when the next forum is, because we put this one off because of our server issues. And we probably will do our next one right after San Antonio, as opposed to in November. Keeping our 2-month, and you'll probably see some of these faces over again. We really appreciate people participating, your great questions. And then again, thanks to our speakers for your time freely given to help educate our patients and make their lives better. Thanks.